All right. Whoa. That works. Okay. Um, I just want to introduce Cindy. She is my co-partner in Health Ministries Association. Yeah. And she is the one that gathered all the stuff for us to eat, which was we're very thankful. So, as has happened in the past, I'm in my doctor's office and I'm saying, you know, I'd like for you to talk to my congregation or my people, and I said, I said that to Dr. Mansour, and he said, you know, I used to love to do those lectures. And I thought, winner. So I am really delighted to have Dr. Mark Mansour to speak to us today. I looked up rheumatology. No, I didn't. On the way to church, I said, hey, Siri, um, define rheumatology. Well, what she said was very interesting because she used a word I hadn't heard in a long time. And that was, she said, it's the study of rheumatism, rheumatism and arthritis and other conditions that are related to the joints, muscles, and tendons. You know, so I think she was right, but I hadn't heard rheumatism in years. How about you? No. So I don't know. I know. That's what Grandma used to say, right? Well, now we know. So, Dr. Mansour, please come forward. I'll let you tell them more about who you are, okay?
Well, I really appreciate you guys taking your Sunday to be here and listen to me babble for a while. And I appreciate Ruth and Cindy, who I've never met, but thank you for inviting me. So going back to what Ruth was trying to say, so my name is Dr. Mark Mansour. I'm a rheumatologist, and what a rheumatologist is a doctor. First of all, I'm an internist. So first thing I do is you study internal medicine, and then you subspecialize in rheumatology. And the term rheumatism is an old school term that goes back, way back. And, you know, your grandma go, oh, I've got the rheumatism, right? You know, grandpa, I got the rheumatism, and they rub their knee or something like that. And it's an old school term for joint pain. But rheumatology is not only dealing with the joints, it's dealing with the immune system and how the immune system can affect joints. And so it's a wonderful field. I love it. I see patients that are much younger than you guys and older than you. So it spans a big group of patients, women, men, affects everybody. I think the pastor said it does, and you can't escape it. It's death and taxes and arthritis. So, all right. So this is a funny quote from Jack Benny, who, you know, when they asked him, he said, you know, I don't deserve this, but I don't deserve arthritis either. And it's true, none of us deserve it, but if you live long enough, you're going to get it. And there's just, unfortunately, I'm kind of starting on a downer here, but unfortunately, there's nothing you can do to stop it. But you can do things that can improve your ability to live with arthritis. And I think that's the important thing. So I thought I'd break up the talk in terms, the first part will be essentially talking about the types of arthritis. You know, there's two main types, but there's over 100 types. Next slide, please. I'm looking at my slides down here and I forgot to say, so you see the Jack Benny there. Next slide, please. So there's over 100 different types of arthritis. In fact, 106, 107, somewhere around there. The two main types that you're going to hear of are rheumatoid arthritis and osteoarthritis. Osteoarthritis being the arthritis we all get as we age. And certain things can accelerate that, and we'll talk about that. There are other types of inflammatory arthritis or autoimmune types of arthritis. Psoriatic arthritis is one. You have ankylosing spondylitis, gout. That's another type of arthritis that can be really influenced by diet. But the two main types, and the type that most of you are going to live with, is osteoarthritis. Rheumatoid arthritis is a more rare condition. So this is next slide, please. This is the definition of arthritis that was given in 2009 by the Osteoarthritis International Society to define what it means to have osteoarthritis and what does it mean. It's a long-winded kind of destruction of the subchondral bone, all these kind of fun terms, cartilage. Really what it means is degeneration of joints and cartilage, bones and cartilage. That's a really simplistic way of looking at it, but I think it's an easy way to kind of define it, and that's what most of us need to know. So destruction, wear and tear of our bones and cartilage. Next slide, please. It is the most common condition to affect all joints. Osteoarthritis affects approximately, over the age of 60, 80% of people will have some form of arthritis in their hands, hips, and knees. I think this is a statistic from this specific international committee. I guess I'm biased because I see people that come to me that are sent to me for pain and joint pain in particular. And I would say osteoarthritis starts in the 30s and 40s, and maybe not symptomatic osteoarthritis, but the joints start to degenerate pretty early in our lives. And we start feeling that as we get older. But so we can be, accurate, over the age of 60, 80% of patients will have radiographic evidence of osteoarthritis in their hands, knees, or hips. Next slide, please. It is the most common cause of disability in the United States. Most of my patients, I have younger patients, which is really sad. They have, they've injured their back at work, they have tough jobs, some sort of labor, whether it's construction. They put in hard days' work and they injure themselves and they just aren't able to do their jobs. So some people keep doing their jobs, and they're tougher than me, but some people just can't. So it's the most common cause of disability. In the elderly, osteoarthritis is second only to cardiovascular disease in terms of its impact on a person's health. Usually it affects people over the age of 40, but again, I see people as young as 30 that are already starting to have joint pain. And a lot of it depends on what they've done throughout their life, how much impact they've had on their joints and their bones. But over 40, that's when you start to notice that, when I first wake up or get out of the car, it takes me like 5 to 10 minutes before, I'm feeling okay, until I go to the bathroom or something. My ankles are creaking or popping. Everybody likes to show me how much they can pop their joints. I tell them that's everybody. That's not a disease. It's just living life. But people like to impress me with their pops. It occurs in the same between men and women. There's no difference, whether you're a man or a woman. Symptomatic OA is more common in women, and I just think that's because women are better communicators, and they're willing to tell you and share that they don't feel well. Whereas men go, there's nothing wrong with me, although they act kind of, we won't say it because we're in church, but they act not nicely. They complain to their wives or they don't complain to their doctors. So what are some of the risk factors that can cause osteoarthritis or can lend a person to develop osteoarthritis? Genetics, there's nothing you can do about your genetics. I'm not 6'3", I don't have a full head of hair. It bums me out every day. I'm 55, I still haven't gotten over it. But But one day I'm hoping that I can get over that. But those are things you cannot control. Your genetics, mom, dad, and so there's genes that code for collagen, things that make up our cartilage, make up our bone. Genes that code for inflammatory proteins. Some people are just more predisposed to developing inflammation, so they're more susceptible to certain foods or activities. Estrogen receptors. I can't tell you how many patients of mine that, after menopause, they start feeling more joint pain, muscle pain, fatigue. So estrogen plays a huge role. Testosterone does too in men. Again, it's probably just we hear it more from women. They let us know. Vitamin D gene receptor, because vitamin D is an important part of, so we all heard of calcium helping with bones, but by now all of you should know, because we're pretty media savvy in this country, but all of you should know vitamin D, calcium won't work unless you take vitamin D. It's the only way we can absorb calcium. So that's why you have to take vitamin D with your calcium. And vitamin D has so many important properties. I mean, we think of more of it a hormone than a vitamin. It can help with our immune system. We now know that people with lupus or rheumatoid arthritis, autoimmune diseases, they do better when they take vitamin D. And same with bones. Your joints are made up of bones. So if your bones are healthy, you'll probably have healthier joints. Not all the time, but that's a good first place to start. So making sure you take vitamin D. But mutations in the vitamin D receptor, how well you absorb vitamin D, can affect your arthritis. Obesity. Now, I don't have any room to talk, but obesity can affect your joints. It's probably one of the most modifiable risk factors that there is. So losing weight. So behind us, we have two of our illustrious leaders in the free world or semi-free world, and they are overweight. So they're more prone to joint pain. Now, that's not only the weight-bearing joints like the back, the hips, the knees. I can't tell you how many people, when they lose weight in my practice, tell me, I lost weight, but my hands feel better, Dr. Mansour. Why is that? I don't walk on my hands. Why should that feel better? But it does, because it reduces inflammation when we lose weight. It's easier for us to move. We have more energy. And so that's why it's so important. Hope I didn't offend anybody with that slide. Good. I got one I loved. Okay. So occupation. Some of us, we can't control what we do, right? I mean, you're not going to be a doctor one day, and you don't want me installing your cabinets the next day. I'm the worst. My shop teacher told me, it's like, Mark, you're a really good kid. You try hard, but you're not taking my class next year. Go take home ec or typing or whatever. You're going to cut off a finger. This is not for you. I'm going to give you an A because you're a hard worker, but this is not for you. I cried. I really did, because I like shop. And so I didn't become a construction worker. So other jobs, coal miners, we still want people digging coal, although, that has other issues besides joints, lungs, and everything like that. But coal miners, farmers, we need farmers, and they work hard. But that takes a toll on the body. And elite athletes, it's a lot of money, but you see these guys in their 40s, they're walking around like they're 90 years old, so they give up a lot. I'd like their homes and the $100 million salary, but they do give up a lot. What's important to remember, next slide, please. What's important to remember, I have a lot of patients that tell me, Dr. Mansour, it just hurts. I don't want to, you're telling me I need to move, I want to exercise, but it hurts. We know that just walking or swimming, I was talking to a person about swimming before the talk. I mean, that's one of the best exercises you do. That's not going to impact your joints. You got that buoyancy of the water, and that's one of the best things to do. But walking does not advance osteoarthritis. Jogging certainly can. So if you're running, probably not the best thing to do unless you've got that perfect runner's body. I certainly don't. But if you have that light body where you can run, you may be able to do that forever. And it's a great cardiovascular exercise, but it's not good for your joints. But walking is something everybody can do. And we'll talk later how studies have shown that walking reduces pain. And then certain sports. American football, this gentleman, I don't know if you can go back, yeah. The gentleman here, 00, Jim Otto. I don't know if any of you know who that is. He's a famous center, Hall of Fame center for the Raiders. He had 12 or 10 to 12 knee replacements. I think 29 knee surgeries through his lifetime. At least 10 replacements. Yeah. And those guys got paid maybe $10,000 a year. Those guys were plumbers in the off season and football players during the season. That's a, I don't want to use the term real man, but that guy's a real man. So football, especially American football, knees, feet, ankles, baseball players. I threw out my shoulder playing baseball. Running, though, running's bad. Knees, hips, ankles. I shouldn't say it's bad because there might be some runners in here. It's good if you're really like, 1% body fat, but the rest of us shouldn't be running. There's other great cardiovascular exercises. So when a patient comes to their doctor, by the time they see me, by the time they see me, they've already got, their doctors told them they have arthritis. And so they're talking about pain in a specific joint. Osteoarthritis, typically it's one or two joints. The older we get, it could be all of them, sorry. But initially they may come in my knee sore or my shoulder or, my foot. And it really hurts when I use it, doc. Like if I was up all day doing stuff around the house and it hurts and then I rest and I'm fine. Or I take a couple Advil and I'm fine. And that's kind of the classic story you hear. We call that mechanical pain. Pain with activity improves with rest. Now, as the disease worsens or you have progression of your arthritis, you can have pain even at rest. That's when you're at that point where you start thinking, more. You start to intervene. So this is the classic. Next slide, please. This is a classic picture of an osteoarthritis hand. This patient comes to me, invariably I'll see this, 10 times a month. I have rheumatoid arthritis. How come? Well, it's the only word I know. I only know rheumatoid. I don't even know what the other types of arthritis are, but rheumatoid arthritis. Somebody told me I have rheumatoid arthritis. My hands are gnarled, and I have rheumatoid arthritis. So this patient does not have rheumatoid. They have osteoarthritis. And they usually will say, I'm really stiff when I get up in the morning. It takes me 5 to 10 minutes to get going. Or after I get out of a car, after a long drive, it takes me a few minutes. But after 10 to 15 minutes of walking around, I don't really feel anything. That's a classic osteoarthritis patient. Morning stiffness lasting less than 30 minutes, usually 5 to 10 minutes. This person has osteoarthritis. I'm looking at their hands while they're talking, and they're like, look at my eyes, not my hands, but I'm already looking at their hands. And this person has involvement, you can see at the distal joint, the DIP joint, distal interphalangeal joint. That joint is not affected in rheumatoid arthritis. That is osteoarthritis. Psoriatic arthritis can do it, but these are classic, what we call Heberden's nodes at the DIP joints and Bouchard's nodes at the PIP joints. And you can go around feeling your joints, and you'll feel that, if you feel somebody without those nodes, you'll know that I've got that. And those are kind of like, it's bone growth, because the cartilage is eroded between the joints, between the bones, and when that bone rubs together, it causes this reaction where you have some bone growth, and that causes these nodes. Next slide, please. Thank you. The main diagnosis, other than listening to the patient, talking to them, x-rays. X-rays invariably will tell me the difference between rheumatoid and osteoarthritis a lot of times. Now, early in the disease, I shouldn't say that. That's not probably true. Early in the disease, it may be hard to tell just with x-rays. But if a 50, 60-year-old person comes in and they complain of knee pain, I check the knees, and I know that, I look at the x-ray and I go, that's classic osteoarthritis. So you see here, this person has already got degeneration in between the joints here. I know it's hard to see on the slide, but the cartilage, the space between the bones has started to erode. And now we're just seeing bone on bone. And that's painful. Here's an X-ray of the knee. It's a little clearer on the knee than the hand, I'll be honest. So if we look on the left, you'll see you've got good joint space. You've got good joint space between the bones. And then if we look at the right knee, it's essentially bone on bone. And that's extremely painful. So every time this person steps, the bone's rubbing on the bone. They may have some instability of their ability to walk. They may have some balance issues and just the pain. Because bones have nerve endings. And when you break a bone, it hurts. So if your bones are rubbing together, that's going to hurt. There's no way to avoid that. And so when it gets to this point, you're not seeing a rheumatologist. You're not seeing your doctor. Not even seeing your pastor. You're seeing a surgeon. Because that's really the only way to fix this. Okay? So when you get to this point, this person on the right, they need surgery. They need replacement. And the surgeon will say, look, I'll replace your knee when you're ready. Like when you tell me I'm not walking, and not walking leads to weight gain, and weight gain leads to heart disease and diabetes. And so it's really important. It doesn't just impact their pain. It's not just pain. They are not doing things with their loved ones. Grandma, you want to go to the beach? No, I can't walk on the sand. I can't do those things. I'm in pain. Grandma will just stay here. So grandma's not doing that. It makes grandma depressed, upsets her, right? So it's not just about pain. It can affect so many different parts of people's lives. And you probably already know that. I'm not preaching to the choir. Treatment. So the first step in treatment is always to not put anything, it's like what your parents said, don't put anything in your mouth, right? We don't need to take medication initially. That shouldn't be our first go-to, right? And the doctor may give you something just because they want you to kind of be quiet. I mean, I don't want to listen to somebody complain about pain. So here's something to take. Instead of talking to you guys and telling you, hey, there are other things you could do first. Let's exhaust those possibilities first. And then we can move on to medication. But so breaking that down, you got non-pharmacologic, pharmacologic meds, and then surgical. That's last. So exercise. Exercise, exercise, exercise. My mom, that picture of that woman on those knees back I showed you a couple slides ago, that person makes my mom's knees look like they're, a day in the park. Those knees are beautiful. Those knees look like a 20-year-old compared to my mother. And I always call my mom, maybe not as much as I should. She's 88. I say, Mom, how are you feeling? Oh, my knees. And every time we're sitting, she's just rubbing her knees. And my biggest regret in life is not telling her at 76 to get your knees done. Didn't force her, because now she's 88. Surgeons don't want to do knee surgery that late. Although I have an 88-year-old patient in my practice that just had bilateral knee replacements, and she's fantastic. She swims every day. She took 2 weeks off, and then she was back in the pool. So she's an overachiever. But it is possible. It just becomes more and more risky as we get older. There's other complications. So studies show exercise can reduce pain as much as an ibuprofen. Ruth, can I share that you took an Aleve last night and it really didn't make you feel better? I did anyway without getting your permission. But sorry. I didn't give you enough time to answer. Ruth knows I talk a lot, so she's begging to get out of my office when she comes to visit me. So that's really important. I want to stress that. And I think a lot of patients think it's, yes. But it's not. It really does. My mom, I'm in pain when I don't move, and I'm in pain when I move, but I'm happier when I move. I feel better when I move. Mentally, I can get stuff done around the house, so I just do it. But she's tough, right? So, I think it's really important to move, and I can't stress that enough. And I know our instinct is when we're hurting to not do anything, to just sit around and go, oh, I can't do it because I'm hurt. But I'm telling you, moving it, you'll feel better and you'll be healthier. Physical therapy, if you can't do it on your own, a lot of times I'll send patients to physical therapy because unless somebody's cracking the whip, people are lazy, right? You know, I'm not looking at you. You just happen to be in the front row. Sorry. He's not lazy. The rest of you are. But no, people are lazy unless somebody's there to kind of like say, hey, what did you do at home today? What are the exercises? Did you do this? Did you do the things we worked on for your back or your shoulder? And then invariably I'll hear, this is one of my pet peeves. I'm sorry. I'm not directing this at anybody, but one of my pet peeves. Well, I went to physical therapy twice and it hurt, so I didn't go anymore. Okay. Tom Brady blew out his knee. He's 28-year-old, top of prime, right? 28 years old at the time. Had to do like a year of rehab to get back on the field. That's a 28-year-old man that is in the prime of his life. And it took him a year of therapy. That was a major injury. So just going to physical therapy once or twice and saying it hurts when I do it is a cop-out, to be honest. And I hope I don't offend anybody by saying that. Now, I'm not saying there's times when you go to physical therapy. There were patients I will not send to physical therapy. I'll look at their x-rays and go, this would be useless for you. We're already beyond that now. But for most of my patients, physical therapy will work. Or the other one I get is I went and it helps, but the second I stop going to therapy, it doesn't help anymore. So it doesn't mean that when your therapy is done that you're done doing those exercises. You got to keep doing them or it won't work. Because, yeah, you're right, it won't work. And you'll be back at square one and you'll be frustrated. So we have to have that. We have to have a heart-to-heart and be real with each other and understand that physical therapy is not just while you're there. It's your life. I tell patients all the time, I got to stretch. I'm 55. I have to stretch going to the grocery store. I have to stretch doing those things to not feel like, oh, when I bend over that my back is stiff. That's part of it. We're not 20 anymore. And part of it is you have to start moving. Physical therapy is very important for a lot of people. Not everybody, but a lot. Weight loss, is important. It's not just important, like I said, for the back, the hips and the knees, the weight-bearing joints. It's important for the hands and everything because that reduces inflammation. So if you can lose weight, it's one of the best things you're going to be able to do for your arthritis. Adipose tissue, fat, that carries inflammation. It creates inflammation in our body. It affects our heart and our joints. So if you can lose weight, you will feel better. And it's just 10% of your weight. 10% is a lot for some people, a little less for others, but we can look around and I'm talking about myself, really. So there's a 50% reduction in pain with 10% weight loss in hips and knees. That's huge. I guarantee you that's more than anything you'll get from Advil or Aleve. I guarantee it. Now, Advil and Aleve is much easier. But we'll talk about the dangers of Advil and Aleve and those drugs in a bit. And this last part of the slide where I kind of already skipped ahead, weight loss helps not just with the weight-bearing joints, it helps with the hands, which is crazy, but it's true. Next slide, please. Other things that we can do, knee braces or wraps. Sorry, point you out again. Cane, I saw a lot of canes today. Not only just for pain relief, but for stability. Because our joints, that vision of grandma or grandpa on the porch going, I feel the storm coming in. That's an old wives' tale, right? Well, actually, joints are proprioceptors. What does that mean? Joints sense changes in pressure. It's why I can stand here amongst other things. It's why I can stand here and know where I am in space and not fall. My joints feel pressure changes. I can feel my foot transferring, right? All that communicates to the brain that, how to keep my balance. So as we get older and our joints become more arthritic, we lose that ability to maintain our balance. And that causes falls. And so you think you're going to stop a fall, you're not. but that cane can. And so that's why it's important to have that cane around, not just for pain, but for safety. But that your grandpa or your grandma, you remember back and them rubbing their knee, that was their joint telling them there's a change in pressure coming, right? So that's why they felt that. There's no magic. It's not voodoo. It's science. Next slide, please. Other non-pharmacologic treatments. I think, we talk about there's a lot of things like occupational therapy is really important. Physical therapy. What's the difference between physical therapy and occupational therapy? Physical therapy works with kind of like muscles, joints, stretching, things like that. Occupational therapy works with patients in their environment, how they work, how they are at home. Occupational therapy is really important for arthritis patients. I don't think we do that enough. I don't think patients ask for it enough, but that's not their fault. That's our fault for not communicating that. But occupational therapy is really important because they can show devices that can help, like things to reach over your shoulder. A lot of people, they can't. Their shoulder's done. They cannot reach above their shoulder. But how do I get that thing off the top of the shelf? I'm going to climb on a ladder and fall, or I'm going to have a device that can pick something up maybe. Or maybe also just putting things lower down so I can get to them. A lot of my patients with really bad osteoarthritis in their hands, especially in this thumb joint where they can't grab something and turn it, there's devices, right? There's devices other than, your wife that may be strong or your husband that's strong. You may want to go and get like a device to open up a can or a jar. They have electric jar openers. They have, manual ones too that work really well. Medications, I think one of the things I wanted to stress on this slide was that having somebody come and assess the home to reduce fall risk. My mom had this done. I thought it was one of the best things we did. They came in 2-3 days, I think, over a couple weeks, and really helped her declutter her home, get rid of some rugs that just, she wanted. She was not happy. But at the end, she was very happy. But in the beginning, it's you don't want somebody coming in and tell you how to live and what to do with your house, but it will help. And then I do this for patients. Like if a person comes in and they want a handicap placard, I'll fill that out, ask for that so you can be close. If you feel like walking, please walk. If it's a bad day and you need a break, use that handicap placard. But if you can walk, get those few extra steps. But it's not embarrassing to ask for that, and I fill those out all the time. Next slide, please. So meds, this is the fun part. Everybody's just give me a pill, doc. I don't want to hear all your other nonsense. Just give me something and make me feel better. And so there are no drugs. Well, this is also the worst part of my visit with patients because they come in here or they come to me from their primary care doctor who's never talked to them about this, and they're like, I'm going to see a rheumatologist, and they're magically going to give me something that's going to stop my disease and reverse it. We don't have anything at this time that does that. We don't. I don't have anything that grows my hair back, makes me taller. We do have weight loss drugs now, and just to really go really quick, those GLP-1 agonists, those drugs have, like, for my patients with arthritis, I can't tell you how many people that have lost 30, 40 pounds and tell me, I don't need to take my ibuprofen anymore. I don't need to take any medication anymore. So those drugs have a utilization beyond just diabetes and weight loss. Yeah. So, but again, nothing we have now will reverse arthritis or stop it. We just don't have anything yet. There have been a couple studies that have been done that showed some promise, but people were having liver issues, so we had to stop those studies. So NSAIDs are still non-steroidal anti-inflammatory drugs, NSAIDs are still the mainstay of treatment. Topical Voltaren gel, that works really well, especially on the knees and the hands, those joints where the joints are close to the surface of the skin. The penetration of the gel works really well to relieve pain. Some people don't like it because it's a pain. I got to put it on 2 to 3 times a day. I can't get dressed because my hands are all greasy. But that stuff works, and there's really very minimal systemic effects, okay? because oral NSAIDs work really well. If I could, I'd put people on a boatload of those things. The problem with those drugs is they can affect your kidneys and your liver. And as we get older, we're already having problems with our kidneys. Some people have more problems with their liver than others, but from other choices they've made throughout life. But whether it be alcohol or fatty liver, but most of us, as we get older, our kidneys start to kind of decline their activity. So those drugs can make that worse. Also, NSAIDs can affect your heart, especially if people are on blood thinners. I'm sure there's a few people on blood thinners in the audience, and those NSAIDs and blood thinners do not mix. And also people get ulcers. So if you take those medications, and you're telling your doctor, I feel like, and they should tell you before you start taking those medications, if you feel any heartburn or excessive heartburn, you should stop and let us know, because you may be developing an ulcer. Other agents, duloxetine. Duloxetine is actually an antidepressant. And why would an antidepressant help my joint pain? I'm not depressed. I would, if you're in pain and you're in that much pain and you're not doing things, you're not going to the beach with your family, you're not going to do things, you're not going to like my mom, she can't go to the baseball games or soccer games with my kids because a lot of the parking lots aren't paved, so she can't walk. That's depressing. And the brain can't differentiate, physical and emotional pain. So if somebody's anxious and depressed, their joint pain will be worse. And if they have a lot of joint pain, they'll have more depression and anxiety. So I've treated patients for their arthritis with antidepressants, and they get really upset with me. And they say, I'm not crazy, I'm not taking your crazy pill. And then they get more upset when it works. Because then they have to admit, like, why would this work? This means there's something wrong with me. And I tell them, no, the brain just can't differentiate that pain. Pain is pain, whether it's emotional or physical. And if you have a lot of depression and anxiety, your pain will be worse. So that's why that medication works. Tylenol, great medication, something that does nothing for me, but Tylenol has no anti-inflammatory effects, so it doesn't work for some people. Some people take Tylenol and do really well. So if you can take Tylenol, that's going to be easier, unless you drink a lot of alcohol, in which case it could be dangerous to your liver. But Tylenol is a good medication. I like to, and maybe so I know a lot of people have questions about like kind of supplements and things like that. I like to use Tylenol with turmeric, because turmeric has anti-inflammatory effects. So that's a natural supplement, East Indian curry spice, and that does have anti-inflammatory effects. So if you mix that with the Tylenol, that could be kind of a substitute for NSAIDs if you can't take NSAIDs because you're on some other medication or you have some other condition that precludes that. The steroid injections, I do those. I probably do 10 to 20 of those a week. People come in, and that's a great temporary reliever, but it's not, again, it doesn't stop it, doesn't reverse it. It basically just is a temporary relief of pain. Hyaluronic acid, those are when it's kind of like a cushion for the joints. Some people swear by them, some people they don't help. Very expensive, and I would say results are mixed with those, but some people do really well with that. That's like things like Synvisc, OneVisc. Opioids, some of my patients, unfortunately, they're in so much pain, they cannot function without opioids. And so that's my last resort in terms of medication. But I have patients, and I'll give them, they'll take one a day, because a lot of these patients are older, and I don't want them to just be sedated all day. But one a day, sometimes even a half a day, just is enough to allow them to do things, and it brings them happiness, and that also relieves pain. But one of the downsides to those drugs is that it makes your body want more and more and more over time. So you have to be really careful and have an honest discussion with the patient and you with the doctor, saying, I don't want something that's going to get me addicted, and the doctor and you have to have that discussion and be honest with each other, that if you ask for more, I'm not going to give you more. I don't want to make this adversarial, but we just have to talk. And then, and again, I only use that for severe pain. And then the last resort for osteoarthritis, surgery. I'm sure many of you in this room have probably had surgery once or twice. But that's kind of the last option. And for that patient with the knee we saw earlier, that's going to be a good option for them because that will allow them to enjoy themselves, do things, and we have really good success with hips and knees. Hips are if you're at all questioning a hip replacement, I would recommend it. If you're somebody that needs a hip replacement, I would recommend that. If your doctor's recommended that to you in the past, I would do it because hips, people typically 3-4 weeks out are already back and living life. Knees, those work, but those are 3 to 6 months. That's not an easy road. And if you do replacement earlier in life, there's a chance that you're going to need a second replacement. Sometimes those wear out. That's why a lot of times the surgeons will come back when you're older. And you're like, I don't want to come back when I'm older because I can't live my life now. And most of the time the surgeons will be reasonable and listen. Risk of surgery, infection, blood clots, doesn't work, right? You're so excited. That rheumatologist, he told me to go get my hip replaced, and now I did it, and I'm not any better. So just like anything in life, sometimes it doesn't work. So that's something to understand when you go into that. But I would say on the most part, most of my patients that get hip replacement are, why didn't I do this earlier? Next slide. Okay, we're moving on to rheumatoid arthritis. I'll try to go through this really quick so we can talk to about the fun stuff, or what I think is fun. Rheumatoid arthritis. What's the difference between rheumatoid and osteo? Now, this is Renoir. Renoir was a French impressionist. He had horrible arthritis. This last picture on the, what is that, your left? Yeah. So your left, so the last picture, they would, if you saw his history or a movie about his history, they would tie his brush to his hands because it would just fall out and he would paint. So it's people do great things despite their handicap, and this is an amazing thing. The other cool thing about Renoir is that he and his son, another cool thing about the movie, they shared the same muse. So she inspired both of them, let's say. I won't tell you how, but watch the movie. If you don't like delicate topics like that, you may not want to watch it, but it's actually interesting. So this is a couple of his paintings, and they asked him about his arthritis. And he says, the pain passes, but the beauty remains. I thought that was a great quote. And these are two of his famous, he's got several, but these are two of his most famous paintings. The two sisters, I can't remember what the one on the right's called. Guy's trying to kiss the woman, and she doesn't seem to be interested. But it is a good painting. So rheumatoid arthritis is different than osteo. Osteo is more mechanical. So wear and tear, we talked about wear and tear. Tires on a car, they wear out over time. Rheumatoid is the body's immune system attacking the joints. For some reason, your immune system, which is supposed to fight bacteria, viruses, keep you protected from foreign invaders, it thinks the lining, the synovium, the lining of the joint is foreign. So it attacks it. And that causes a lot of inflammation, pain, and then joint destruction. It almost is like a little animal has gone through the joints and taken bites out, if you look at x-rays. This is kind of a busy slide just telling, it's almost like if you were to be infected with a virus like a cold, your body would do the same thing. But instead of the antigen or the foreign thing being presented to the antibodies, it's the synovium, the lining of the joint. Some people think it's triggered by a past infection. But what that does over time is it destroys joints, affects ligaments, so it makes joint laxity. It can be a very destructive process. If not treated, it's irreversible damage. So the earlier we can treat these patients, the better. So this is different than osteo because if we know early, we can stop it. And so that's why this is important. Risk factors, I put these twins, this is from the Arthritis Foundation. These two women are identical twins. So positive family history is important, but it's not the only thing, because even if your identical twin gets rheumatoid arthritis, 80% of the time you'll have it, but there's 20% of identical twins that don't get it. So there has to be something else besides just genetics. And so one twin may have been exposed to something that the other twin wasn't. And so We also know, so the positive family history, smoking. We did a study showing that patients that smoke, their arthritis is far worse, especially in rheumatoid, but all types of arthritis, far worse than patients that don't smoke. Vitamin D deficiency, again, there's the vitamin D deficiency. So just making sure you're taking vitamin D every day. That's not the only treatment, obviously, but it can help. And then again, bacterial and viral infections have been implicated in causing or triggering RA. So the incidence is far less, where I was saying, 80% of patients have osteoarthritis by the time they're 60, 0.5 to 1%. So selfishly, when a patient comes to me with rheumatoid, that's a horrible disease. But selfishly, I know when they walk in, I can stop it. I can fix them, right? Osteoarthritis is much more frustrating for me and my patients. That's the one most of us get. But this is 1% of the population. So every time somebody comes in and says they have RA, most of the time they don't, right? Somebody told them, I have the rheumatism, I have the rheumatoid arthritis. They don't. They have osteo, but we investigate. Peak age, 45 to 65. Yeah, so a lot of my patients come in, my 20 and 30-year-old patients come in and go, I'm not old. Why am I getting the arthritis? Well, you can get it as young as 25, and we do have patients with juvenile. We don't call it juvenile rheumatoid arthritis anymore. We call it juvenile idiopathic arthritis. Those, you can have patients 2 and 3 years old that are getting joint pain and swelling, which is devastating because it affects their development, and that's awful. But it's just as awful if a 45 to 65-year-old, 75-year-old gets it, because it can affect so many different things. The 45 to 65-year-old, it's going to affect their work. Can't work if you don't treat RA. I mean, it's devastating. 65 and older, they may be retired and they're not working, but again, it limits the fun they can have and what they can do with family and friends, and that takes a toll. So all those things, that's why it's so important to identify that, because we can really impact it. This is a classic patient. We can see the hands are a little younger than the other person's hands, but you can see the swelling. Sometimes I can't even see the knuckles. The person will come in, it looks like they have pillows on their hand. And so the hands are usually the first joints that are involved. And this is not the same thing. It's not where the patient comes in, I'm sore for 5 minutes, or I work too hard, and then it's gone. These patients, if you're not treating them, they will have persistent pain for weeks, months. So they'll present with swollen, tender joints. Next slide, please. So the diagnosis on this one, again, history. I have a lot, and it's usually acute onset, rapid. 2 weeks ago, I was walking my dog and my knee started hurting, and then within a few days, my hips, that's the other thing, symmetric, multiple joints, not just one or two like with osteoarthritis. It's usually the whole body, and it comes on very quickly. And they also have a lot of fatigue, They just can't function. This one's interesting. The pain, different than osteo, the pain improves with activity, right? So the more I move, the more I walk, I loosen up, I feel better. That's what we call, again, morning stiffness, or consistent with inflammatory arthritis. So they can also have like a low-grade fever, unexplained weight loss. A lot of times when patients come in and go, I can't lose weight, I'm kind of a little saying it's probably not autoimmune, because autoimmune disease takes a lot of calories for the immune system to mount that response. And so just like when you're sick with cancers or other diseases where the immune system or the body's using a lot of calories, people lose weight unexpectedly. And then a lot of times they don't eat because they're in so much pain. I don't feel like eating. And then rheumatoid arthritis can do other things. It can affect the lungs, whereas osteoarthritis does not affect organs. So osteoarthritis patients don't have lung or heart involvement, but rheumatoid arthritis patients can. Lung is the most common place that's affected other than the joints. So they can come in complaining of a cough or shortness of breath. I've even had some patients, I always call them my tricky ones, because the lung disease happens before the joint pain. Now that's really rare, but I have a few of those patients. So they come in, it's lungs, and they're like, why am I seeing a rheumatologist? And I go, well, your pulmonologist is thinking that based on your lab test that your disease is related to rheumatoid, but I don't have any joint pain. And then, 4, 5, 6, 7 months later, they'll start complaining of joint pain. So physical exam. Now, these are slides probably from the 70s, 80s, 90s. We should never see hands like this. So you're seeing on the first one, you're seeing a swan neck deformity. You're seeing ulnar deviation where the hands turn like this and you can't pull them back. The bones of just basically, you have MCP contractures of the medial, the joint, these big knuckles here. So that's permanent. And then the last one's a boutonniere's deformity. We should never see that anymore. That's a thing of the past. So if I'm seeing this, this means that either the patient didn't go to the doctor or their doctor didn't diagnose them. Or sometimes patients see me and they don't want to take medication. And I'll show them these pictures and they just don't want to take medication. And so that's sad for me, but I understand where they're coming from. But I just think at this point in time, this is a waste. We should never see patients like this anymore. So other things that can help us with the diagnosis, other than the physical exam findings, labs, rheumatoid factor. But again, rheumatoid factor, it's not the be-all, end-all. 30% of patients that have a negative test can have the disease. So you don't have rheumatoid arthritis because, my doctor said I don't have RA because my rheumatoid factor is negative. That's just not true. You could. Also, if it's positive, it doesn't mean you have rheumatoid arthritis. So again, you have to kind of use other modalities, physical exam, talking to the patient, other labs. CCP antibodies are great because when they're positive, they're very specific for RA. So when CCP antibodies are positive, that person 95% of the time has RA. Okay? So that's a very helpful test. But again, only 70% of RA patients have that test. So you can't just rely on it alone. ESR and C-reactive protein, those are tests we do to look at inflammation. A lot of times patients that have RA are going to have high levels of inflammation in their blood. That's going to show up on blood tests. And so that's a really important test. And that can also help guide me on how, not only in how they're doing, how they tell me they're doing, but that can also tell me if the medications are working to reduce their inflammation. High levels of inflammation are not only bad for their joints, so I know their main goal is to not have joint pain. My goal is that I know if I leave this untreated, rheumatoid arthritis is like diabetes in terms of heart disease. It's a risk factor for heart disease. Most people with rheumatoid arthritis or autoimmune disease die from heart disease because of all the inflammation. So if we can control that, not only are we controlling their pain, we're letting them live long because of their hearts. We're preventing that. Preventing further progression of heart disease, I should say. The CBC, a lot of patients, we talked about fatigue. A lot of patients with chronic fatigue will have a lot of, inflammation, and that inflammation results in anemia. The bone marrow just can't make red cells fast enough because it's making a lot of white cells. And so those patients will have anemia. That's another way I can maybe diagnose the disease if I see chronic anemia. And then the liver function test, RA, and the kidney function test. RA, rheumatoid arthritis, does not affect kidneys and liver per se, but I check those tests just because the drugs I use can affect the kidneys and liver, and I want to make sure it's safe to give patients those drugs. And x-rays, I think, are probably really the hallmark. MRI is a great test, but unfortunately with MRI, it's super expensive, and insurance companies don't like to pay for it. But x-rays only show damage that's occurred. So by the time, if I see a bad x-ray, that means I'm too late. I should have been treating this patient 2-3 years ago. But x-rays are cheap, and so insurance will pay for that. MRI, that's about, $5,000-$10,000. And so insurance companies don't like to do that, but there's a lot of times where an MRI will show me active inflammation of the joints that I can't see with my eyes or with my hands, and that will be good. We're getting better at ultrasound is the next one, and ultrasound is very effective, but you have to have somebody that's experienced in reading ultrasounds of joints, and there's not too many of those people around, types of, radiologists. Drugs, NSAIDs can be used in both rheumatoid arthritis and osteoarthritis. NSAIDs do not, non-steroidals like ibuprofen and Aleve, they just treat pain. They do not stop the progression of the disease. DMARDs, disease-modifying anti-rheumatic drugs, those are the ones that I wouldn't be a rheumatologist unless we had these, and specifically the biologics, which we'll get to in just a minute. Prednisone, that's something I'll give to patients, and usually right at the beginning, because prednisone is the only thing that will work really quickly to reduce pain and swelling, and it really makes my patients feel better, gives them hope that there's a chance that they'll get better. Hydroxychloroquine, it's a drug that got a lot of media attention during COVID still. It wasn't really effective in treating COVID patients because we tried, but it's great for arthritis, lupus patients. It's an anti-malarial drug. It doesn't really suppress the immune system. It's an old school antibiotic used to treat malaria, and it helps reduce pain and fatigue in RA patients, lupus patients. So it's one of my favorite medications. It's got very few side effects, but it does take a while to work. Then there's the non-biologic DMARDs, methotrexate, leflunomide. Those work on DNA synthesis, so they reduce the body's ability to produce white cells, which are the cells that attack the joints and cause inflammation. So they're very effective. But they don't work very quickly, and not everybody responds. And there's toxicities related to the liver with those drugs. Finally, the biologics, the TNF alpha blockers that came out around the early 2000s, just before 2000. Again, I wouldn't be a rheumatologist without those drugs. Those drugs changed how we treat RA. They get about 70% of patients into remission. I'm probably overstating that. This is being videotaped, so I apologize, but it's pretty close. Those drugs really do change lives. It's really rewarding to see somebody that comes in, and I'm not being paid by the drug companies, right? You didn't get any money for that, but those drugs are amazing. But they have downsides, right? They're very potent immune suppressors, so they can put you at risk for infection. There's theoretical risk it can increase your risk of cancer because the immune system surveils our body for cancer. But that's extremely rare, and it hasn't been proven, but there's a lot of data to suggest it does maybe increase the risk. And so those are great medications and really change people's lives, though. People go from, initially I'll say, okay, I'll see you in a couple months. No, I need to see you next week. I need to keep talking. And I go, you don't need me that often. It's not going to work that quickly. And then, well, it's too long. I don't want to wait that long. And then by 6 months on the drug, they're like, why do I even need to come see you? My labs look good. I don't have any pain, And I go, well, because I got 2 kids I got to put through college. And plus, that's one of the reasons. That's one of the reasons. The other reason is because those drugs are potentially toxic, and I have to monitor safety. So non-biologic DMARDs can cause that, and we have to monitor their labs. And but these drugs, just make me just be a little more alert. I have thousands of patients on these medications, and they do great. But every now and then, somebody has a reaction, and you have to be prepared for it. And you need to tell your patients what they're getting into, right? Informed decision, informed consent. But without these drugs, I wouldn't do this job. So, and again, I'm getting no money from the pharmaceutical companies saying that. But that's what science is about, drugs that can help us get better. And these drugs don't just treat pain, they stop the disease. That's what's very different between rheumatoid and osteo. I wish I had a drug like that for osteoarthritis, because then I'd get that hair transplant I've always wanted. I'd make a lot of money. But seriously, it would change people's lives, like these drugs for rheumatoid arthritis. It's only 1% of the population, though, with RA. And that's the sad thing. We're working on it. So besides drugs, I want to kind of apply this not just to rheumatoid. I think this is more, not that you guys weren't having a great time before, but this is kind of where, this is the enjoyable part. So we talked about 2 main types of arthritis. We talked about osteoarthritis and rheumatoid arthritis. Now, exercise, so we're going to talk about how do we manage that? How do we live? How do we live with arthritis? How do we improve our situation with arthritis? And what are the things we can do at home without a doctor, without a surgeon, you know? And exercise is for both rheumatoid and osteoarthritis. I kind of stressed this on an earlier slide, but I just want to make sure. It does not make your arthritis worse. It just does not. You may feel pain, but that's not making your arthritis worse. If I took a 20-year-old who's never run or doesn't run, and I asked them to go run 5 miles, what would happen the next day? They would be sore. And they're 20. Okay? So it's not that I'm saying you're not going to get sore and stiff. You are. But you're sore and stiff doing nothing, sitting. So this will at least improve it's when you exercise, your body releases hormones, proteins that improve mood, reduce anxiety, reduce inflammation. And so that's part of exercise. It's not just getting in shape. It's about the joy of it and being happy. And what it does, not just for your joints and your stiffness, but for mobility. The patients of mine, I have like 80, 90-year-old patients that come in. I know I'm not going to be like them when I'm their age. They are just superstars. They look like they're, on vacation, 20 years old, and just, their bodies are old, but they move well because they exercise, they move, they stretch, they do yoga, they swim. They swim. They do things that keep them in shape and improve their balance. Because I guarantee you, the less active you're going to be, your joints are going to get stiffer. They're not going to get magically better. The arthritis isn't going to go away by just sitting in your chair. And what's going to happen, I sound like I'm lecturing you. I don't mean to be, but I just know how much of a difference it can make, and that's why I'm trying to, encourage you. But those are the patients that do well. And also, you build muscle strength. And the more strength you have, the more balance you have, the longer you can live independently. I mean, that's the goal, right? Because we know one day they're going to put us in a home, or I hope my kids do that. Maybe they'll do something worse. I don't know. But it's like, Mom, Dad, you can't live there anymore. You just, but we want to avoid that day as much as possible. It's inevitable, but we want to put that back as much as possible. And if we can, we want to enjoy the time we have as much as we can. And that's only going to come with being healthy. And it's not going to happen if we don't do stuff. I had like a medical issue when I was 50. I'm 55 now. I was up to 267 pounds, so I started getting into shape, walking my dog, lost about 50 pounds. And it's the best thing. It saved my life. I jump rope every day, can't lose any more weight. But my daughter says, Dad, as much as you work out, you should be really skinny, which makes me feel very happy. Thank you, honey. But exercise is important. And I know when I exercise, I get to work, I'm happier, I have more energy, I feel better. I'm not the model I want to be, but I feel better. And the balance issue, and it's at the end of the slide, I kind of hit on it already. Balance. With arthritis, balance becomes such a big issue, and falls. And if we can stay strong and healthy, that's super important. And that will allow us to be safe, number one, but to also enjoy our independence longer. That's what we're working on. So exercise is important. I brought up the Tai Chi. I live down in Sacramento. There's a group of older Asian people that are always doing Tai Chi. And that Tai Chi, I mean, it is amazing. They did a study at the University of Washington in Seattle showing that Tai Chi can reduce the stress on the knees. And it can't just be the stretching and the flexibility that comes with it. There's meditation. There's a bunch of other things that are produced that make our brain feel better. And I'm convinced that that's what helps. And walking and Tai Chi and things like that. Yoga. I heard a couple people doing yoga. All those things are important. But again, with balance and strength. This is a woman, Patricia Katz. She did a great study. 2015 was her first study. She's done several since. And her study was really interesting. It was an RA patient specifically, but you can translate this into osteoarthritis. So she divided her study into 3 groups. And there was one group where they gave like a Fitbit to and said, walk 5,000 steps a day as part of walking, not as part of your going to grocery store or working, but walking. She gave another group a Fitbit, 2,000 steps, I believe. The third group, they just gave a handout saying exercise is good. Well, the third group was useless. But the other groups that had this thing, because I use this thing, look, I burned 731 calories today. I ate 17,000, but I burned 731. I just got to figure that's coming up too. But the food stuff, that's important. But this woman, Patricia Katz, Dr. Katz, did this study where they divided, not just her group, they divided these people up. And the 5,000 steps a day, they reported a reduction in pain, improvement in energy level, improvement in mood. That's what, I mean, they controlled for medications and, age and all that, gender, all that. So that's why that's important. Because not only does it improve pain, it improves energy. I'm just so tired, Dr. Mansour. But the next time, and I don't want to offend anybody, because I don't know your ages, but the next time I have an 80-plus-year-old person come in and say, I dug a ditch and I put in like 20 miles of piping in my house and then I had to take a nap at 2, I'm going to hit him in the face. Because I guarantee you 40-year-olds aren't doing that. But that's impressive. But I hear that all the time. But I got to take a nap at 2. So take a nap. But that's okay, right? What do you do? What do you have going on in the afternoon? You got to go to work? Nope. Are you buying your wife? Are you cooking dinner for your wife? No. What are you doing? Take a nap. That's fine. But people that exercise, and digging ditches is not exercising. Well, I'd work on my ranch. I got a 5-acre ranch. I got a 10-acre ranch. What's the size of a good ranch? Forgive me, I'm a city boy. So what's the size of a good ranch? 10 acres? Is that good? 150? Okay, I was a little off. So that's a lot of mowing, right? So, and if you can't hire somebody to do that, you got to do it. But that's not exercise. That's great for your muscles and stuff, but it's still going to make you sore. But it doesn't give you the relief that exercise does. That feeling of, I don't want to say peace because I sound like really new age, but peace, right? It gives you that happiness, that joy, right? That's what we need. And mowing your 150-acre ranch does not do that. It does not do that. There's no joy in that. You might take pride in it, but there's no joy in that. So we talk about decrease fatigue, reduce fall risk, reduce anxiety and depression associated with pain. Because that's one of the big things that my patients, I can't tell you the anxiety and depression I see with patients. I can't do this. I'm worried I'm not going to be able to stay in my house. I can't do my job. I can't, my family's asked me to do stuff and I can't do it. And that's a lot. I used to throw my Christmas party every year, and now I can't. I got to tell my daughters, can they host the party? Because I can't cook and clean like I used to. That's anxiety. That's depression. You can get over it, and you can tell, well, just get over it, but it hurts, right? But the pain reduction is pretty impressive. They reported, I think, a 65%. I may be overstating that, but they reported a significant reduction in pain. So now we move on to the diet. Next slide. Thank you. Yeah, please. Yes. It is. Absolutely it is. But I guarantee you it's not the same exercise as or you're not going to get the same benefit mentally from that of walking, smelling the roses, walking around the lake, listening to the birds chirp, listening to an audiobook, listening to my pastor's sermon from the day before. So I want to listen all week till I get to hear him next week, right? Right? I want to, so that way, suck up, yeah. I like rock, Riding a bike is fantastic. But I'm not saying you're not getting a benefit from doing that. I'm just saying it's not as beneficial. How about that? It's not the same degree of benefit that it is from like walking your dog or walking with your spouse, right? Sometimes, I don't know, and not everybody has a great marriage, but I'm just saying. What's that? Mentally, yes. Yeah, thank you. Do you want to come up and give the lecture? So yeah, absolutely. Absolutely. So the mental benefit, because you're going to get some satisfaction, mowing the lawn, right? But you're going to get more satisfaction of listening and walking and talking to a friend, or just being in silence and just hearing nature, praying. There's a slide. Okay. So, but going to diet. Any other questions? I know we're going to have a question and answer. Yeah? Okay. If you guys have questions. But the diet's important. And there's a million different diets you can look up on the internet. I will tell you the best diet in the world is still the Mediterranean diet. It's not as, sexy as some of the newer diets that have come out, carnivore, keto, all that stuff. Nobody over 50 really should be doing keto. You could do keto kind of more healthy, so I shouldn't say it like that dramatically or be that authoritarian about it. But keto's not a great diet because there's a lot of fats in it that can affect your joints. When you're 20 and 30, that's okay. When you get older, it can be harder. But the Mediterranean diet lowers blood pressure, can help certain types of cancer like colon cancer, or reduce the risk of certain types of cancer like colon cancer. And all the foods in the Mediterranean diet are anti-inflammatory in nature. Okay? So that's why it's so important. So not only does that anti-inflammation help your joints, helps your heart. This is a very important diet. So next slide. So what is the Mediterranean diet? So we're talking lean protein, chicken, fish, especially fattier fish like salmon, which has a lot of omega-3 fatty acids, which is good for your heart, good for your joints, good for inflammation. Fruits, all fruits are good, but some fruits are higher in sugars than others. The fruits that are really beneficial are going to be like berries and cherries, lots of antioxidants, lower sugar. So those are going to be better. Healthy fats, olive oil, avocado oil, but olive oil is a staple of the Mediterranean diet, and that's better. Vegetable oils, you really want to avoid those if you can. There's some vegetable oils, especially the ones that are, sold, mass-produced. They're not as healthy, and they're going to be less healthy fat. Vegetables, leafy greens, all of those things will help inflammation. Nuts, not so much peanuts, but walnuts, pine nuts, pistachios, and almonds. Those are some healthy nuts that can be used. A handful of nuts is like as much fat as a Big Mac, just so you know, like peanuts. So just be careful. That's my danger. That's my problem. Also, if you can eat at this place, you have no stress. So if you could find where this is being served, you should eat there. Plus, there's a glass of wine. Wine, there's debate on whether that, I think in moderation, we now know that wine can be okay. Not the whole bottle, but a glass would be good. What's the fun in that, right? It's just a glass. But again, mainly the diet works by reducing inflammation by using foods that reduce inflammation. Not only are they not pro-inflammatory like some foods are, they reduce inflammation. So you get a double whammy there. So they reduce things like C-reactive protein, which is an inflammatory protein. IL-6, which is interleukin-6. That's an inflammatory protein. All those things. So we reduce those, we reduce inflammation. Weight management. I like the Mediterranean diet. I like to eat like 3 servings, so that's the thing. So weight management. So portion control is very important, but But if you eat this diet in a portion that's appropriate for you, you will lose weight without really having to do anything else. It gets harder as we get older, I know. I hear it all, trust me. And it's a great diet, not just for your joints, for your hearts, for reducing cancer risk. So it has so many benefits. And again, find this place and retire here. Although this is beautiful here. I mean, this is like, I think I came up here and somebody said God's country. I don't know. Yeah, this is beautiful. This church is beautiful too. So you're blessed. Now, these are the foods to avoid. Next slide, please. So here again, I hope I'm not picking on anybody. I don't want anybody to get upset. But we have two of our former presidents here, one our current president and one Bill Clinton. And they love McDonald's, okay? And here you have President Trump up there. He's got a whole bunch of them. He's super happy. Bill got a lot of, I don't remember when Bill Clinton went to McDonald's. He was on a jog somewhere, and they went there, and they were on him for a year for that. I guess it never changes in the media. They love going after the president. But so high-fat foods that you'd find at McDonald's, red meat. Now, some red meat's okay, like filet. It's got to have less fat. But, ribeye, that should be a special occasion, like once every other day. Just kidding. I'm bad. So processed food, fried food, you want to avoid that. And red meat, you want to eat sparingly. Because all that is not just bad for your heart, but can promote inflammation. So people like that are really diligent or really strict about their diet, they tell me all the time that I can tell I ate something. Because normally my joint pain is worse when I eat this, right? So they can tell if you are, but you have to have fun. I'm not saying eliminate all that. You have to enjoy yourself, and if you're out with friends or family, have a little piece, but just try moderation. Processed foods, the sugars, the fats that are added to processed foods, I mean, it's criminal, But I understand. I mean, people need to make a living, but it's criminal, kind of like what we put in our bodies. I remember people freaking out about the vaccine. And I would go, have you been to a grocery store? You're worried about the vaccine? Okay. I mean, salt. Salt. I avoid salt for blood pressure issues. And there's some people that debate whether salt affects blood pressure. For me, it does. But salt can result in fluid retention and swelling, which can affect the joints. Not so much inflammation, but swelling can affect the joints and increase your blood pressure. Sugary drinks, both our current president and Bill Clinton behind me, they drank diet drinks. I don't think those are really any better, but it's less sugar. And then like white bread, white rice. Those things can promote inflammation. It's non-refined carbohydrates. They will not only, again, be unhealthy, they will promote inflammation. Nightshade vegetables, I think this is debatable. A lot of people say the nightshades cause inflammation. There's chemicals in the nightshades that produce inflammation. I have several arthritis patients, and again, this is not a study. This is just anecdotal, my experience with my patients. I have patients that eat tomatoes and potatoes and do just fine. I have other patients that can't eat that. So kind of play around and see, does that affect me? Do I feel worse when I eat that? Okay? I think it's just when they grow best, maybe, they call them the nightshades. Does anybody know? Oh, yeah. Okay. Eggplant too, thank you. Eggplant, definitely. But that's just a description of the general term that's used for like tomatoes, potatoes, peppers, eggplant. Okay, so we're going to move on to my final thoughts here. I'm a child of the 80s. And although He did a lot of things that weren't great. He's still probably my favorite president. I showed a few presidents today. Kim Jong-un of North Korea, our president, Bill Clinton. But back in a time when people had decency and kindness in the 80s, I feel like an old guy. He was our president. And so kind of like, I model all our presidents because that's when I came of age. I was 10 when he became president. So that's kind of when I started paying attention. And so my dad loved Ronald Reagan. My mom was a Carter guy. And they would sit at the table and talk. And at the end, my dad would say, Nina, I love you. Gave her a kiss. Thank you for dinner. And they would, treat each other with respect. And I wish we could do that today. But why I put this on here was not because I'm trying to pick a president or convince you of anything. I put this on here because Ronald Reagan said his advice was, this is a quote, live simply, love generously, care deeply, speak kindly, and leave the rest to God. And I think attitude, and why I put this in here is because attitude plays a huge role in arthritis. You are not going to go to your doctor and have a magic wand waved to take away all your pain. It's just not going to happen. And I know you guys know that. I'm not saying that you came here thinking I was going to give you the magic. There's a few, if people paid extra, they get the magic one. That's later. It's an extra fee. Ruth, did you tell them about the extra fee? But no, there's no quick fix. But attitude is where it starts. And I have patients, they walk in here, patients that are terminal. They come to my clinic and they look like they're on summer vacation. They know they're dying. They know they don't have a lot of time. And they're happy. And I don't have that courage. But they do, and they're inspiring. But I know that those people that have that attitude always feel better. So I thought this was just a beautiful, And I know people have criticism of Ronald Reagan, but I thought this was beautiful. And if we could all live like that, it would not just help with arthritis. I think we'd all get along better and be happier. So anyway, next slide. So I leave you with this. Mark Twain, another great American, and it's true. If you don't mind, it doesn't matter. And if I hurt, but Doc, I have a Korean War veteran, one of my patients, and every time, and I don't know if he forgets, but he comes in every time and he tells me, I go, how are you doing today? And he goes, well, Doc, I'm on the right side of the dirt. And I laugh, and every time, because he tells me the same joke every time. And he's pretty sharp. I don't think he's demented or anything. He just tells me the same joke every time. I do that as I get older, but I think that's that attitude I'm talking about. And that's kind of what Mark Twain's saying. We all hurt. Life is pain, whatever you want to say. My baseball coach, football coach in high school. Life is pain, Mark. But anyway, I really appreciate your attention. I'm done. So thank you for listening. Yes.
Some of you, I promised we would get through at 3. You're free to leave. But if you want to stay, as long as Dr. Mansour is willing to answer a question, feel free to stay. And if you have a question, if you'll raise your hand, I'll bring the mic to you because we want to hear it.
So there's a lot involved in that question. So what do you mean by gene therapy? Like specific, like stem cell? So we're not really doing any gene therapy right now. We're doing stem cell, where we can take a person's stem cells or stem cells that have been saved from other people and inject those into knees. And there's been some really good promising things. It can be very beneficial for certain types of arthritis, specifically osteoarthritis. Nothing yet that's been used for rheumatoid, although that's being worked on. So the side effects really are few. It's just expensive. It's about, I think, 45 grand a shot. Not yet. They're doing more and more. PRP, which is platelet-rich plasma, that's where they take your blood and spin it in a centrifuge and take the platelets out and inject that. That's FDA approved. That used to be quite expensive, and that's working really well. But in terms of gene therapy, like for example, like the mRNA vaccine, I don't think the best part of the mRNA vaccine is going to be for infection. I think it's going to be in putting genes in people to help with arthritis and other things, other conditions, heart, other viruses, things like that.
Just one moment. Before you leave, be sure to fill out your evaluation. You may leave it on the table. Thank you. Okay.
If you have fibromyalgia and osteoporosis, did they work together?
Yeah,
'Cause
so
it's an
yeah, so fibromyalgia is a really, like I see a lot of patients with fibromyalgia. So that, so most patients, so if you have like chronic pain for a long time, that can lead to fibromyalgia. And so a lot of patients will have fibromyalgia and rheumatoid arthritis or fibromyalgia and osteoarthritis. But fibromyalgia is more of a neurologic condition. There's really nothing wrong with that person's muscles or joints. They just feel it there. The pain is in the pain is in the nerves. So that's why the drugs that work for fibromyalgia are going to be like gabapentin, Lyrica, duloxetine. Yeah, yeah. So no, you feel it in your muscle, but they've done biopsies, MRIs, and they've done so many things. Yeah, that's probably what they told you because they don't know what they're talking about. But that's not true. I see a lot of fibromyalgia patients. I mean, that could be a whole other talk. But yeah. So food, exercise. My patients that exercise with fibromyalgia, the hard part with fibromyalgia is sleeping because of chronic pain. So if people can sleep better, they feel better, and exercise will help you sleep. I don't think I said that in my slide, but exercise will help you sleep. Yeah. I think you are very lucky because most of my that's the worst pain I ever see is fibromyalgia. I call it the F word. You're welcome.
I love this. Thank you so much.
Oh, thank you for saying that. Thank you.
I'm just wondering, would you repeat your comments about estrogen receptors and testosterone?
Yeah, so estrogen receptors, so there's some genetic abnormalities that may predispose people to osteoarthritis more than others. And so those are mutations in those genes, and they may have more symptoms like following menopause. Or with men, men have what you call it menopause or whatever. We all over time have less effectiveness of our steroids, right? Estrogen in women, testosterone in men. We all have both testosterone and estrogen, men and women. But a lot of my patients, as they get older and go through menopause, they report more muscle and joint pain, and that's pretty classic. We also know that estrogen is very important in bone health, right? So that's why women tend to have more osteoporosis. And so that's because as women get older and estrogen levels go, bone density goes down, and because joints are made up by bone, that kind of also plays a role.
My daughter has rheumatoid arthritis.
I don't know. Right to your mouth.
My daughter has rheumatoid arthritis, and it started off, her skin became very, very hard. And now her finger is swollen very large, and she has these purple marks that go up her finger and huge blisters all over. And they have tried several different medications. I've never found anything. They said she has 2 autoimmune problems, and they told her, don't panic. This medication we're giving you is also used for cancer. Now they say that the only thing that they can do left is to give her some kind of injections.
Yeah, so it's interesting that you say that because one of the things rheumatoid arthritis usually doesn't cause blistering of the skin or any kind of things that you're talking about. The thickening or hardening of the skin is typically what we'll see in scleroderma. So when they say she has two autoimmune diseases, it sounds like, and again, I haven't seen her, but it sounds like she might have like a mixed connective tissue disease, like features of arthritis and features of scleroderma, because that causes that thickening of the skin. And a lot of times it doesn't respond to the medications we use in rheumatoid arthritis. Yeah, so I think probably it might not be, because there's so many different drugs, but so it might be that she's been misdiagnosed. And again, I don't want to put ideas in your head because I haven't seen her, but it just doesn't sound like the right diagnosis. Yeah, I think sometimes as rheumatologists, there's so many, these diseases don't always, treat everybody the same or work the same, but you're welcome. But they a lot of times will say, well, I think this is rheumatoid arthritis. And I'll even tell patients that because I'm not completely sure. We'll take a break.
When you give platelets on a regular basis, does that affect having the arthritis or hurt the arthritis or anything like that?
You mean like doing the platelet-rich plasma? Yeah, no, you don't want to do them all the time, but no, it doesn't stop the progression. Is that what you're asking?
Well, not that it stops it, but does it hurt?
No, whereas steroid injections can over time, and that's why we only like to do the steroid injections every few months. Yeah, with both osteo or rheumatoid. We use that mainly in osteo, though.
Why can't we find a substitute for salt that tastes like salt?
That's beyond my pay grade. Trust me, when I had a episode, where my blood pressure went through the roof and I had to be hospitalized to get it under control, and I had to give up like a lot of salt. And salt's in everything. I mean, you can't even have a sandwich. I mean, the bread is really like, that's enough salt for the day, right? And that's just a slice of bread. So yeah, and I tried all those salt substitutes. And my friends they were so sweet. They brought over all these spices to put on there and and my daughter and wife, we went through the store and we threw everything out. And that lasted about a year, by the way. So do what I say, not what I do. Yeah, unfortunately, I don't know really why, but yeah, I agree with you. There's a lot of money in it. You want to work on it together? We'll figure it out. Yeah.
Do you deal at all with treating people with hyponatremia?
Well, some of my patients get hyponatremia from different reasons. Yeah, different. Yeah.
Because I try to stay away from the salt, but then my sodium is low when I go for my blood test.
Yeah.
And I'm not thinking as clearly as I should be because my sodium is low.
So you're on that other side of the spectrum where I would say you could probably get away with having more salt than the average person because you have hyponatremia, without having the ill effects of the swelling and everything like that. And again, remember, salt's only bad is if you're overtaking it. And it sounds like your body, for some reason, is kind of getting rid of it. So there's a lot of conditions. I'm sure you've been worked up, hopefully, of why you have hyponatremia. Yeah, because there are different diseases that cause hyponatremia. Some people just have low salt levels, but if it runs in your family, but you just need a formal workup because there can be some more serious health concerns with hyponatremia. But if you have hyponatremia and they cannot find a cause and there's no other health concerns, you could probably get away with having more salt than, let's say, I could. Yeah, salt is, yeah. You'd be surprised. It's like cigarettes. Your physical addiction to cigarettes is gone in about 7 days. So why you want to smoke is because you crave it. So you just have to find a way to, take a walk. I told you about walking, right? Yeah. Yeah, some people just really like it, but the more you get used to cooking without salt, the better. And, and then you feel like, and I love salt too, don't get me wrong. I just don't want to have a stroke. So that's the choice. Yep.
One question.
Yeah.
What, do you have an opinion on protein as a supplement? I mean, does that have an effect on the,
Yeah, well, I think it depends on a couple things. The types of protein, we talked about in terms of diet or like taking,
Diet,
and then also depends on kidney function and other things, right? So it's not a one answer for everybody. But in general, lean protein is really important. You need lean protein. So, and you should if you get that through your diet, that should come from, healthier meats like chicken and fish, and the occasional red meat, but avoiding red meat if you can. But again, and these are not hard, fast rules. These are rules that, again, with moderation. But for protein, getting protein through your diet through healthy fats. Now, taking a protein shake, like I have a lot of my patients doing protein shakes because they get older, they don't want to eat. It's really, their family comes in, says, my mom doesn't want to eat. And she's like, shut up, don't tell the doctor. And so I just don't feel hungry all the time. And I go, well, you could drink a small shake, like a Boost or an Ensure or something like that.
so it's more as a supplement if you're not
But you
eating?
need protein. If you're not getting it through your diet, you do need protein. Otherwise, you'll have muscle wasting and weakness, and that's not good.
Okay.
Oh, it's just no, not really, not really. So if you can get it through the drink, it's just that if you're gonna if you can do it through your diet, that's always the best way to do it. Yeah, that's great. They had a big problem in Germany because they almost outlawed people being vegan because they weren't getting enough protein. So there's a bunch of, right, we have so much good information about how to be vegan and get enough protein. Tony Gonzalez, I don't know if you know who that is. He's a football player, tight end for the Kansas City Chiefs years ago, not that long ago. But he was a stud. I mean, the guy was so muscular, but he was vegan, and he did a whole special on how he became vegan and how he maintained his weight as an NFL player and his strength by substituting other forms of protein, beans, things like that. Yeah, certain grains, like healthy grains, right? Like non-processed or, I don't want to get too off and tell you something that I know, because I'm not a nutritionist, but I do know that, beans with certain types of other foods can be a substitute for meat.
You just have to back off and not do so much. And it's like, where do you find the balance?
Yeah, I think the only person that can answer that is you. Yeah, and that's when we get into what she was asking me about fibromyalgia, because a lot of my patients, because they're in so much pain, they don't sleep, and that makes them more fatigued and have more pain. So you do have to find a way. Like I would, for somebody with that degree of arthritis, I would be in a pool. I would be in a pool. I would ask my doctor for water therapy. Yeah, I wouldn't swim. I would just walk. Like there's a great El Dorado physical therapy. I'd ask a referral there. What's that? In Shape does it too, but they have that outdoor pool. So the shingles, the Folsom one, if you can get down there. I grew up in LA, so for me, like I remember when I first moved to Sacramento, and they're like, "Oh, that's clear on the other side of town. That will take you at least 15 minutes to get there." And I go, "It takes me 2.5 hours to go 13 miles in LA." But the thing is that if you can, so Shingle Springs is great. Thanks for bringing that up.
Yeah.
Shingle Springs is a place you can ask for a referral there because they have physical therapy there. And I don't know if it's run by El Dorado PT still, or if they do it privately in-house, so that will be paid for through your insurance, or doing the Folsom one. They're really good because that's a pool that's 84 degrees. I mean, it's meant for rehab.
Shingle Springs pool is fine.
Okay. Thank you, Ruth.
It's 80 degrees. I can, that they keep it at least 80 year round. I mean, in the winter. So
Yeah, it is important for it to be warm because getting into a cold pool, that's good for swimming, but it's not good for rehab. Yeah, see, and can we be honest? That's the stuff I would tell you to back off of. Yeah, yeah, because that's the stuff that gets you into trouble, not the exercise, because the exercise will make you feel better. But you're right, people need to do those things to survive. And that's going to cause you pain. So that's when you might consider trying like turmeric. We didn't really talk about that. How much do you take? Okay, that's good. That's good. So you want to take at least 1,000 milligrams twice a day. And that inhibits cyclooxygenase, which is the same enzyme that ibuprofen inhibits. I think I talked a little bit about that. Yeah, but even if you had liver disease, you could do that. Even if you had, even patients that have end-stage liver disease can take quite a few grams of protein of Tylenol. Naproxen is a little more dangerous. So what you'd want to do is yeah, I would do the Tylenol with the turmeric, which you're already doing. Maybe that form of turmeric's not helpful for you, so you can try switching it. I know there's a brand on Amazon called Curamed that's really good. Okay, Curamed is a pill form though, not liquid. Yeah. I think you're talking about Qanol. Yeah, yeah. So Curamed's a little different. That's a really good one. It's a little more expensive, but it is good. Yes, yeah. But it sounds like you've got really bad arthritis. And one of the things that we didn't talk about, there's a El Dorado community acupuncture. You've done it, doesn't work. Yeah. Was that local here that you did that? Okay. Yeah. So did you try it at least once, or did you try? Okay. Okay. Pain is pain, people say that all the time, but that's why Navy SEALs, they give them a story to tell because they know they'll get broken eventually because pain is pain. Pain is bad no matter how tough you are. So it doesn't mean you're a wuss if you have pain. Pain is awful. But I think the things that you're doing to kind of survive are making it worse. And that's easy for me to say because I'm not living your life, but I do know from what you're telling me that you're doing around your house, there's not a quick fix for that. I can't give you better advice than to tell you to stop doing that, but that's stupid for me to say. Right? Yeah. Yeah, yeah. I think back arthritis is probably the worst of all kind of like degenerative arthritis. And especially if you had trauma, right? Yeah. So fractures in the vertebrae, those take time to heal too. And again, I know it's been a year, but it can take years to overcome like compression fractures or fractures in the spine. But you know what? Have you tried? Can we go to that? What about duloxetine? Have you taken that? The duloxetine? Because you're overwhelmed with your pain. And it makes you sad and it makes you anxious. So I would ask for duloxetine because you've tried the other stuff. So like an antidepressant. And I don't mean to say that you're whining or depressed. I'm saying that you're anxious. You're in a lot of pain. And that makes you sad. And that needs to be treated because that's part of getting better. So if you've exhausted all those things and you haven't tried the duloxetine, that's what I would ask for.
Could you spell
And
the
ask for help. Sorry.
could you spell the turmeric that you like on Amazon?
Curamed.
Okay, that's what I thought. Also, is there a way that I could get a copy of this presentation to share with my husband?
Yeah.
If the recording is good, I'll send you the link. Okay, yeah. Thank you, Dr.
Thank you guys
Mansour.
for staying and listening.
Wonderful.
Oh, do we have one more question?
Ginger.
So,
Ginger, I have crystallized ginger and then I do ginger tea and that. And it seems to help me, but I'm not sure if it really is.
so if I told you that it doesn't help you, does that matter? Good point. Good point. I would keep taking it. If you feel it's helping you, take it. Look, glucosamine chondroitin, right? That stuff came out probably 20 years ago because it worked in dogs and horses. We can't ask dogs and horses if it works. They just run more, so we assume. Maybe there's a different reason. But they've done study after study that says it doesn't work. I remember one time I was in the grocery store with my wife, and I put some of that in the cart, and she goes, "But Mark, you say that doesn't work." And I go, "Well, a lot of my patients like it, so I want to try it." If it works for you, and you have the financial ability to pay for it, then I would keep doing it. Yeah. It's not going to hurt you. And ginger does have some soothing effects. Ginger, mainly I hear about nausea and things like that, but soothing the stomach. But if it helps you with joints, keep doing it. Oh, duloxetine, Duloxetine. You might grow a horn in your head. So tell him, you know what I would do? I would have this, what's your name?
Annie.
Annie? I'd say, Annie, the meloxicam really works for you. These are the dangers of this. And so if I put you on this, if you have some upset stomach, you let me know. And then we're going to check your creatinine and liver function tests every 3 to 6 months to make sure we don't see any damage. And then if you could, you can have a blood pressure cuff at home and make sure it's not bumping up your blood pressure. So that's what I would tell you. So tell your doctor, "Hey, doc, I understand the risk, but this really did help me get through this. And is it okay? Like, I'll let you know. I'll take it with food, and I'll let you know if I have upset stomach." Just because you take it. Now, ulcers are a definite risk, but doesn't mean everybody that takes it gets an ulcer. Celebrex, I'll be honest with you, Celebrex is great for people that have a history of GI issues or have upset stomach. If you never complain and don't have a history of GI, meloxicam's a better pain reliever than Celebrex. I use Celebrex only in patients that I know have a known history of peptic ulcer disease, but it's not a good pain reliever.
Close his hand now, and I've got to go milk a goat for a lady in July, and it's like, that's going to be tough.
Yeah, you have a lot of obligations, and you have a lot of arthritis, so I would ask to go back on that meloxicam. And just tell him, who's your doctor? Okay. Yeah, just tell him that. Most doctors don't. It is. But I'm going to go back to the first thing I said to you, Annie. And I say this with love. You're overwhelmed with your pain. If we were in a private setting, I would tell you that same thing. I don't want to embarrass you or anything, but you're depressed about your pain. So depression doesn't mean you want to jump off a building. Depression means that you're just overwhelmed, you're anxious, you're upset. And if you told me you weren't upset about your pain, I'd call you a liar. Because it doesn't mean that you're just woe is me. But those signals that are going to your brain, like you're just thinking about, I got to milk this goat. I got to, clean my roof. I got to clean debris off my property. I got to do this. So that just keeps building and building and building. And those signals that are going to your brain causes pain. And you need to stop that. Yeah. So talk to him about the duloxetine and tell him to go back on the meloxicam.
And I did not catch the correct dose of the Curamed turmeric.
So the Curamed, interesting, that's a good question. It's 750 milligrams. You could take 1 or 2 of those a day. I'd start with 1 for the first month and then, go on as needed.
Does that, sorry. The Terminec capsule with black pepper.
Yeah, so there's this idea that I have to take it with black pepper because it helps me absorb it better. Not necessarily true, but black pepper can help you absorb it better. But as long as the dose is the same. So, a lot of people say, I put it in my soup, or not my soup, but I put it in my food. You have to have enough curry to feed a small village for it to make a difference. You have to take quite a bit of it to make a difference.
What was the milligrams?
1,000 milligrams.
Okay. Are we through? Thank you. Oh, is there another question?
Let's see, it is the Pregabalin or Ly?
Pregabalin, Lyrica.
Yes. Yeah, that.
Lyrica, yeah.
Yes,
So
that's it,
that's
that's right.
in pain that's for nerve pain.
I have really bad where with my arm. My arms and legs are burning.
Yeah,
really
so
bad.
that burning pain.
Yeah, yeah.
That's
yeah.
that's
Oh,
Lyrica.
That's it. Thank you.
Yeah.
So I think I might stop the other one, the Celebrex, because I really don't have
Yeah, if you don't have pain, don't take that. It can affect your kidneys. Even though it's okay for your gut, it can affect your kidneys. Yeah. Well, yeah. I know everybody in this room has arthritis. I didn't notice. You shouldn't have told me. I'd be asleep too if I was sitting there. Those are comfortable chairs.